A very good morning to everyone who have gathered here. It gives me immense pleasure to welcome our esteemed faculty members, students, and staff to this insightful session on evolving concept of palliative care by Padma Shree Dr. M.R. Rajagopal sir, often referred to as the father of palliative care in India. Sir, we are truly honored and privileged to have you amongst us. So let's begin the session by seeking God's blessings. I invite Reverend Raja to lead us with a word of prayer.
Shall we all look to God in prayer? Our gracious Heavenly Father, thank you, Lord, for this beautiful day that you have added in our life. We come before you with hearts full of gratitude for the gift of life and the sacred calling to care for those journey through the pain, illness, and vulnerability. Lord, as we gather today to reflect on the theme evolving concept of palliative care, Lord, we acknowledge your presence among us, the God who is near to the brokenhearted and who walks with us in every season. And this morning, we are much thankful to you for the wisdom and the dedication of Dr. M.R. Rajagopal sir. Thank you, Lord, for the great commitment towards the broken community and all the labor that he has put for excellence in the palliative care. May today's reflections and discussions inspire us to serve with great compassion, deeper understanding, and unwavering hope. And your word is reminding that if you spend yourself in behalf of the hungry and satisfy the needy of the oppressed, then your light will rise in the darkness and your night will become like the noonday. O Lord, we pray that to offer not just treatment, but the presence, not just medicine, but mercy, not just a care, but Christ like compassion. Father, we commit this program into your hand, Lord. You bless us, bless each participants and patients we represent. May your spirit lead us into the greater understanding and actions. And we ask this prayer in Jesus' name. Amen.
Thank you, Reverend Raja. If I can stop one heart from breaking, I shall not live in vain. If I can ease one life, the aching, or cool one pain, or help one fainting robin unto his nest again, I shall not live in vain. Echoing the words by Emily Dickinson, today we have amidst us an epitome of compassionate care. It's my honor to introduce our distinguished speaker, Dr. Rajagopal sir. Dr. Rajagopal is the founder and chairman emeritus of Pallium India and adjunct professor of global oncology, Queen's University, Canada. Sir did his medical education from Trivandrum Medical College and postgraduate degree in anesthesiology from AIIMS Delhi. He later shifted gears in his career and with his colleagues, he initiated a palliative care service in Calicut Medical College in 1993. Today, the community-based movement has grown to a network of more than 350 palliative care centers in Kerala and across India. Some of its remarkable initiatives include efforts to remove regulatory barriers in the availability of oral morphine for pain relief, contributing to the amendment of NDPS Act of India, the government policy on palliative care for the state of Kerala, and formation of Government of India's National Program for Palliative Care. The international organization Human Rights Watch honored him with Alison D. Forge Award in 2014. He was named one of the 30 most influential leaders in hospice and palliative medicine by the American Academy of Hospice and Palliative Medicine in 2017. In 2018, Dr. Rajagopal was honored with Padma Shree, the fourth highest civilian award given annually by the Republic of India. With great respect and anticipation, I now invite Dr. M.R. Rajagopal to deliver. And we also welcome Sir's wife, Chandrika ma'am. Hearty welcome, ma'am. I now invite Sir to deliver his session. Thank you.
Can you make this work? Is it working? Okay, thank you. Yosna, thank you very much. Jennifer, thank you for this opportunity. Reena, thank you for bringing me to my welcoming me for the 4th time to Vellore. And thank you all for being here. We have some important things to talk about. But before that, Josna, whenever somebody refers to me as the father of palliative care in India, I have to remember history and say, express our gratitude to Dr. Lucito D'Souza, who first brought palliative care to India. He had started the Shanti Avedana Southern in Mumbai, 1985 or 1986, at a time when I had not even heard the expression palliative care. Onco surgeon who still lives in Mumbai. So let us all be grateful to him. And to the many teachers who have shown us the way. I'm not going to deliver a lecture, Jyotsna. It's more going to be an interaction, but I'll just say a few words to start with. I know that there's a heterogeneous group here. I know there are oncologists. Maybe there are other oncologists. Can you please raise your hands? Okay. Any non-oncology medical specialists here in the group? Okay. Thank you for being here online also. From the time when we had started palliative care, the concept of palliative care has evolved already. So we might as well start by bringing whatever clarity we can into it. Sorry, you had put a slide on just now. Can I bring it back? This is how your duty and my duty is defined in India by the bioethics division of ICMR. Our primary duty is to mitigate suffering. That is the 14th century aphorism, to cure sometimes, to relieve often, and to comfort always. I mentioned that with a specific reason. I wish I had known this when I was a young doctor. I had not accepted suffering as the focus of care. What I learned was to walk away. There was no other way of dealing with the suffering. You see somebody starving. Maybe even in those days I could afford to buy the person a meal. I never did. Not in the hospital. Outside I might. But in the hospital, you just turn the other way and walk away. If you see agonizing pain, you would learn to ignore it and concentrate on the disease. And somehow I started even feeling a sort of irritation. Thank you. Is this okay? Is this audio okay? Is this audio okay online? So I'm in this confession box to say that through half of my career, I learned to walk away from suffering. And then when I learned palliative care, it was liberating. It was liberating because I did not have to go away, turn away and run from suffering. It empowered me to deal with it. And that's what palliative care can do. Now, if it's our responsibility, once you accept this as our responsibility, of course, it involves curing the disease, it involves diagnosis, it involves all the science. But here the humanity also comes in. Everybody has compassion in you. A bit of compassion is there in every person. So, what I learned to do was to stifle it, be medically focused. But if we choose to accept that duty, then empathy has to come in. Compassion without empathy can be a little cruel at times. Without empathy, then I would decide, okay, you have a problem. I will tell you what to do about it. You do that. I won't be able to see your side of the problem. I won't be able to put myself in your place. So, compassion has to be accompanied by empathy, and without that, it can be a little hard. What palliative care did for me, training did for me, was to give me permission to be compassionate. If I could make that proclamation, I would say, hey, you have my permission to be compassionate. You don't have to stifle it. We can express it. Now, if we have to do that, we have to know how to face suffering. What do you do when somebody is rolling in pain? What do you do when a man or woman is abandoned in the hospital? This must be not at all strange to you. Patients being brought to you and then running away. Do we react only by cursing those relatives? Or are we able to see it from their side also? Most of the time, what kind of society have we built for people to stifle their own compassion for their own people and abandon them, the circumstances? So, when we choose to see the suffering, then we have to decide to do something. I particularly ask the non-palliative care people to think about this. The World Health Assembly, the decision-making body of World Health Organization, 11 years back, came out with this resolution, encompassing everybody. The chaplain, it would be applicable to all healthcare providers. Integrate palliative care into your work. When we did those short online courses for oncologists, we thought there would be only 4 or 5 coming in, and each was oversubscribed. So there are a lot of people who welcome the opportunity to be able to show their compassion, and that's what we achieve by integrating palliative care into not only oncology, all healthcare. And it says, the same resolution says at all levels, meaning at your level of tertiary care, at the secondary levels of care, and the primary levels of care. This is for all healthcare providers, not only for doctors and nurses, medical social workers, pharmacists, the person at the gate, the security staff. Everybody has a role, including the health secretary and the health minister. At all levels, across the continuum of care. And that, it's okay, I stopped the slide show. I paused it. If everybody is to do that, integrate it, how can we do it? That is something that we'll talk about, we'll discuss together. Palliative care, therefore, is mitigation of serious health-related suffering at all levels of care. I repeat that palliative care today is not only how it was defined for the patient whose disease was no longer responsive to curative treatment. That's how it was shown. Today, palliative care, the WHO redefined it in 2002 and said, removed the word when the disease is no longer responsive to curative treatment, and said it is for improving quality of life in all life-threatening conditions. Is there a problem there? Do you see any negative aspect of calling palliative care or reserving palliative care for all life-threatening illness? Is it okay with you? Right? What's your problem with that? Could this roving microphone be available over there? I think your face tells me, the second person from there in the second row, your face tells me that you have something to tell me. I misread your face. Who is going to respond to this question? Any problem in reserving palliative care? That is palliative care, I repeat, is mitigation of serious health-related suffering and improving quality of life of the patient and the family. Any problem in limiting it to life-threatening illness? Please respond so that we can make it an active discussion. Sister, you have something to say? The microphone is not far away. Please tell me.
Sir, resources and the time that we may not have if we expand it across all illness. So that's one concern.
Doctor?
Yes.
What's your name, Doctor?
Balu.
And what do you, which
radiation oncology.
Radiation. True. Dr. Christopher Booth, a medical oncologist from Canada, wrote an article. It says, first of all, that's the title in BMJ Oncology. First of all, I feel loved. That's the title of the article. In that he compares what's happening in his country, Canada, and Regional Cancer Center, Trivandrum. In Canada, he says a busy oncologist may see up to 15 patients in a day. And here, what would be the numbers that you people deal with? He quotes the average in RCC. I don't remember the figure, but you must be dealing with much, much higher numbers. So that's a challenge, isn't it? How can you spend time for all this? Anybody has a solution to offer? And I am saying at all levels. That includes the primary health center at the time of the monsoon with all the fevers, the man or woman may be seeing 150 patients a day. What can we do? Anything we can do? Any suggestion? Even if I am very busy, let me make a couple of suggestions. Even if I am very busy, I can still convey to the person with my eyes, with my face, maybe with a smile. How can you be too busy to smile at any point of time? I know it's hard. It's hard when you have a lot of degrees. I don't know if you remember the physiology. I don't know the principle, but the more degrees we have, the muscles become more rigid. With a super specialization, then it's very difficult to smile once you enter the gate of the hospital. Including MSc nursing, the problem is there. Doctorate because makes it very hard. We still smile. And if the person's face looks a lot of or she looks a lot anxious, we still say, you look anxious. I see you are in pain. Just validating that suffering. This happens as the person is invited and is allowed to sit down. I have already started integrating palliative care there. Considering it as a person, not a container of illness. It starts from there. And then acknowledging and validating the person's suffering, conveying an important message. You look very anxious. I am going to look after you. We are going to look after you. I don't know how many patients are seen in Vellore. The figures are astronomical. And I keep coming across repeatedly people coming here and feeling very grateful to this institution. If in addition, they can also carry home the feeling that somebody cares. It starts there. I have, at my age, started infesting hospitals more and more as a patient. And I come across this. Being dealt as a disease, not as a person. Nobody sees my anxiety, nobody sees my fears, nobody validates it. Okay, it starts there. And then if I say, feeling breathless, when after your quick examination, I hope will be also examining me, not only the screen. After that quick examination, your prescription, instead of that useless neurobion tablet, if it includes something for my pain, a rational prescription for the pain. No, I had not studied pain management 2 generations back. I fear, doctor, that you also have not learned pain management, unless you are in palliative care. I did not know that I did not know pain management. I thought I knew. After all, what's it about? An NSID? You can't sleep? Okay. A sleep medicine also. I did not know how to evaluate the different kinds of pain. I did not know how to distinguish a neuropathic pain from a colicky or spasmodic nociceptive pain. That I cannot see in the MRI. I can only see in the patient. And when my prescription includes something for my symptom, some integration of palliative care has already happened. The one other aspect that needs to be on major, not one other aspect, many things, but on major aspect that has not been included would be end of life care. Now, this is another issue. Doctor, we talked about relieving, mitigating suffering. Can you think of our noble profession as a vehicle for worsening suffering, for causing suffering? Do we not only not treat suffering, do we induce suffering? Do we inflict suffering? I don't mean the smaller things like what happens with an auto rickshaw drive in Vellore. That's another thing altogether. I don't even mean the numerous tokens that have not been seen and the wait times. Many of those things are inevitable, I suppose. Any comment about infliction of suffering by us? Take a guess. How many people in India would be destroyed financially, brought below poverty line by catastrophic health expenditure? Doctor, thousands? Tens of thousands? Lakhs? Millions? I'm giving you several options. Pick one. Choose one. He's busy Googling to see the number of people destroyed by catastrophic health expenditure. What did you find? No? Hey, come on, you must make a guess. Only then I am moving forward. I'll have a drink. Yes? Huh? Yes. It's even more. Crores. 55 million Indians, 5.5 crores, which is more than 4% of the population, are destroyed by catastrophic health expenditure in a single year. More than 4% of the population. India is one of the worst 12 countries, according to World Bank data, in this matter. So when that useless neurobion is prescribed, we are adding to the problem. When we choose a non-generic prescription type of medicine that is promoted by only the industry, we know that the cost can be enormously different. When we choose a paracetamol infusion, when we know that the bioavailability of oral paracetamol is excellent and the only difference is a slightly quicker action, when we also know that injection paracetamol is also cause an infusion device, the pain of injection and intravenous puncture, when we also know that the brands usually used are the fiercely expensive brands, when it's available for 23 rupees, also one brand for 1000 milligrams, and also 950 rupees. And when we know that how the expensive ones they choose, we are becoming a party to that infliction of suffering. We just don't know that we are doing that. Sorry to paint this grim picture, but it's good to remember that when we have written that prescription, a child in that family goes hungry. When instead of using oral morphine, you stick those patches, the transdermal fentanyl patch, somebody goes hungry because it's so fiercely expensive. I know there are specific situations when you may choose it, but as a routine. And the trend in India is that in India, our poor country, the fentanyl consumption is increasing multiple times the increase in morphine consumption. Okay, catastrophic health expenditure is one. One more. Where do, there is that philosophical question, where do birds die? Nobody knows the answer, but where do people die? No. I'm not asking about your institution. Things may be very different. But in most hospitals in India, this is one of my worst fears. As I told you, I am at an age when I have to think about it. I have to think about where I'll die. I have to think about how Chandrika is going to deal with that situation. Where will I die? Because we are dressed like this and have some money in the pocket, unless she fights really hard, I am going to die in an ICU. Right or wrong? After the turn of the century, this disease was not there 25 years back. Strange. Okay, I'm an anesthetist by training. I was an intensivist. Intensive care was for people who are likely to come back to life with intensive care. Intensive care units were not death houses in those days. Now, people have to, as soon as the oxygen saturation drops, as soon as the sodium drops, oh my God, I challenge any one of you, unless you are lucky enough to get hit by a truck to die with a normal serum sodium, unless that infusion is going in 3%, causing more phlebitis and more pain. That's part of the dying process. It's part of the dying process normally to have the oxygen to drop, for the limbs to get cold, for the sodium to drop, because there is no energy for the sodium potassium pump. We don't treat that when we know that the person is coming near the end. What you do, if you have the time, is to sit and hold the hand or have somebody available so that the person doesn't die alone, or to spend 5 minutes with Chandrika, if at all you have the time, because she will be alone with her grief. This is growing. Hey, and does this happen everywhere in the world? Doctors, particularly nurses, some of you may have worked in Western countries. Anybody who has worked in a European country, Western European country? Okay, I can give you the data. I'm not sure if I have it in the presentation. No, I did not include in the presentation, but I can easily give you. This study published in 2021, certainly not old, from Western European countries, shows that only Western Europe, USA may be different. We are not invoking USA here at all. In Western European countries, 89.6% of people in ICU, when the disease was considered no longer responsive to curative treatment, if there was no reasonable chance of coming back to normal life, not normal life, reasonable quality of life, 89.6% were taken out of life support systems and instead given palliative care and allowed to die in peace. You want to take a comparative guess from within Indian hospitals? This study was published fairly recently, I don't remember the year, certainly after 2020, by Dr. Rajkumar Mani, R.K. Mani, whom many of you would have heard about, maybe the best known intensivist in the country, who works in Delhi. He and colleagues published a study which showed that while only 10.4% in European countries die on life support systems, here it happened in 70% of the situations. So the risk for me is that at that time, my life will be stretched, my dying process will be stretched out over weeks by artificial life support systems. At every time, there is a tube going into the most sensitive part of my body, the respiratory tract. And you very efficiently will come with all sterile precautions, push a catheter down my throat every half an hour, as deep as it will go, and twist it as it is withdrawn. How will it feel? A doctor friend once told me that what he felt was like a red hot iron going into him and being twisted as it was withdrawn. A tube in every orifice. Chandrika allowed to come in for 5 minutes in the morning and 5 minutes in the evening. If she wants to touch me, she cannot. She'll be scared. Even if she is allowed to, she'll be scared with all the cables that I am covered with. She will stand aside, watch for those 5 minutes before being thrown out again. What can be the justification for this horror? So, what am I saying? Our role is to mitigate suffering. And we have been caught in a particular situation, a medical system, where at least in these two ways, catastrophic health expenditure and infliction of suffering at the end of life, we make matters worse. We can do better. Very clearly, we can do better. And that's by integrating palliative care into intensive care. That tribe is also growing. People who have create protocols that can create processes for one adequate pain relief. Those who have worked abroad amongst you would know that Western intensive care units always have sedation protocols, pain relief and sedation protocols, which are not there in most hospitals in India. I know there are exceptions. I know CMC Vellore is an exception from the average healthcare system, of course, but in most hospitals there are none. So this, sorry if I overdid it. Sorry if I hurt you. I am sure some of you were hurt because in this group, I am sure there will be at least 5 people who have gone through the experience of similar end of life care in your own family. I am not asking for a show of hands because it can be a painful experience. If anybody is willing to share such an experience, most welcome. So, what's the answer? Answer is integration of palliative care into all healthcare. Is it possible? I mean, practically feasible? I can tell you that more is happening than you ever imagined. Okay, I've been mourning about problems. Let me tell you about the positives. The NDPS Act, the act that prevented access to morphine, was amended by the Indian Parliament in 2014 after 19 years of efforts. Now, quite legally, you can access oral morphine. Doctor, after this, even if you are employed as a single doctor clinic somewhere in a rural area, you can still access it, provided you have a certificate showing that you have been trained in pain management. The law doesn't specify what that training is. That will be up to the state drug controller to decide that your training is acceptable. But if you have it, there are no barriers. You can access it. But that law has not been implemented in our country even after 11 years in every state. There are some states where it's not implemented. In Tamil Nadu, it was implemented very well. In between, after a change of drug controller, there was some problem which has been rectified. So that's possible. We can treat pain now, wherever you are. If it would be nice if palliative care is included in the medical and nursing curriculum. It has been included. From 2019, pain management, end of life care, attitude, ethics, and communication, all these are part of the medical curriculum. There are more than 670 medical colleges. Most of them do not have palliative care. Who will teach it? That's something that we are trying to facilitate. Nursing curriculum, BSc nursing curriculum, yes, has it already. So from 2022, fairly recent. Again, huge implementation gap. Many of us are trying to fill that gap. So it's already in the curriculum. Hopefully, in another 10 years, we'll have a new generation of doctors and nurses understanding palliative care, integrating into their care, who will be able to treat pain, breathlessness, punctuating wounds, or any symptom scientifically and with compassion. So, India's National Health Policy of 2017 includes palliative care, but only at the primary level. So there are many more things to be done. In a high-income country, a policy generally is translated to action. In countries like ours, usually it may not be. So we have to be catalysts in that process. I spoke longer than I planned to. So shall I stop here and take, Jennifer, shall I take questions? Yes.
So thank you very much, sir. Maybe you can take a seat. So what we hope to do in the next 30 minutes is, first I would like to ask some questions on your behalf to sir, and then we will come back to the audience here and those who have joined online. If you have any questions, you can ask sir directly. So thank you, sir. So you did speak a lot about palliative care and how the focus is on suffering, and it is almost like giving permission to be compassionate, but also about quality of life and mitigating suffering. What we see in real life is, in most situations, people understand palliative care as, okay, when a patient needs morphine, let's send them to palliative care, or when the acceptability of disease is difficult, okay, counseling. So palliative care is made synonymous to either terminal care, end of life care, give morphine, do some counseling. So can you please expand a little more as to a right understanding of palliative care, so there is enhanced integration and acceptance within the healthcare fraternity?
Thank you, Jennifer. Yes, you are absolutely right. And most people, when my work in Trivandrum in Kerala, it's a non-government organization. The majority of our patients are poor. They generally come for treatment early, but all the middle class or high income people who come generally come in the last 48 hours of life. Because for them, palliative care is giving up, palliative care is end of life. For the poor people, usually there are no alternatives and they have no problem, they come early. So here we have a huge problem of popular misunderstanding. That's understandable because the concept evolved. Dame Cecily Saunders, who started this movement, started by treating people who were dying with cancer. So naturally that heritage is stuck. She herself changed it, but today that happens. So for me, palliative care, you are an oncologist, sir. Palliative care is what you will give me when I come to you with severe chest pain, not knowing whether it's really cancer. Even before the diagnosis is established, you treating me with compassion and trying to answer the questions. And if you would not have time to answer all my questions, but outside, if there is a social worker or a knowledgeable nurse or somebody who is able to answer my questions and treating my pain, and just in those few seconds conveying that you will look after me. Thank you. The process has started. From that time, palliative care has to begin when my suffering starts. So Jennifer, that will mean, okay, there are two or three institutions where every patient who comes to oncology is seen by a palliative care doctor. Is that practical for the country where we have 7 to 10 million people in serious health-related suffering? Remember that only less than 30% of the palliative care needs are in cancer. More than 70% is from all other diseases, including HIV and a lot of neurodegenerative disorders. So the bulk of palliative care delivery happens with every healthcare provider, all the doctors, all the nurses. So tomorrow, what I see is that when I am coming to the hospital with that pain, I won't be immediately seen by a palliative care doctor because it will not be necessary, because he will treat my pain. He will treat my breathlessness. But if he has a problem, and because he doesn't have the time for proper evaluation, or with the usual protocol, my pain is not relieved, then he refers me to you. So the bulk of palliative care will be by every healthcare provider. Is there a look of disbelief on your face? Just think of the medical student and nursing student learning palliative care. And generally in Western European countries, this is what happens. Any doctor would prescribe morphine. Any nurse would know how to assess pain. Their palliative care has started. And as I told you, there where health intensive care is also compassionate, and people are taken when taken off life support systems and adequate palliative care is given. All that is part of it. Will it be better if I stand there, Jennifer? No, because there are online also. It's okay.
Online audibility is okay now? Okay, thank you, sir, for reiterating that palliative care is actually everybody's business. So considering the mismatch in the so-called specialist palliative care group and the need for palliative care with its need to integrate into every serious health-related suffering, we have to start accepting that integrating palliative care is my business, is each of our business. But can you still give some guidelines or some pathway where, when we talk about early integration, much of the evidence comes saying that integration has to happen with specialist palliative care, and even there is still not much of clarity when and where do we do this referral or integration. So, any thoughts on that?
So thank you. Two aspects to my answer. First, integration of palliative care does not start with a referral to palliative care center. Integration of palliative care starts with every doctor and every nurse and every healthcare provider doing it himself or herself. That's the first point. Up to a point, and referring only the difficult issues to the palliative care unit. I have no doubt in my mind that a referral of every patient to a palliative care unit will not happen in this country or any country ever. It's just not practically feasible to have a palliative care team for every person with any illness. So this is my emphatic answer. But there is another problem. How about the social, emotional, or spiritual suffering? Will you have the time, doctor, to go into the issues? But if you may still find that the person doesn't have anybody to care for her or him, you find abandonment, then there has to be a system. And that cannot be done by palliative care professionals sitting in the palliative care unit and addressing the problem. Because there the community has to come in. Even in the matter of referral to a hospital, how does it happen? Generally with a neighbor or an extended family member taking the initiative. And you know the family.
Hello.
So what we have done in Kerala is to allow the community to come in. I know that it happens even here in some departments. NGOs allowed to come in and help. There is a, I don't have the reference with me at the moment. There was a study done on a patient with a long-term illness who all are involved in giving healthcare. they found that only about 23% of the healthcare was given by professionals. The bulk was, of course, given by a family member, some huge percentage, and then by the community around them or extended family. So allowing them to come in is a huge advantage. I know that in the Regional Cancer Center in Trivandrum, there are two non-government organizations given some space within the hospital, so they are allowed to, they are able to guide patients and support them, and you don't find them wandering around all over the place. Where should I take this sheet of paper? But within the same campus, there are two other hospitals, including my alma mater, Medical College Hospital and Sri Uttara Center, where NGOs are not allowed to come in. And there you find people starving. Unless a patient in the bystander in the next bed buys them food, they starve. They get discharged and they get thrown out because there is nobody to guide them to a facility that will take care of the abandoned people. So the second part of my answer is allow the community to come in. Let people help. Non-government organizations, community-based organizations.
Thank you, sir. With so much of need, I think we need to be flexible to allow anyone to come in to help that will translate for better care for the patient.
Jennifer, can I put in a comment there?
Yes, sir.
Anyone can come in after training. We are allowing lay people to come in and help people. Imagine the potential risk. They can actually, volunteers are taught in some of them. Very few are willing to do a dressing change, because there are these people with chronic wounds that last years in the community. So volunteer learns to do it. Imagine they don't wash their hands after treating one person and goes and treats another immunosuppressed patient next to. They would be party to manslaughter, right? So they have to learn. They have to learn how to talk. They have to go by the ground rules and core values, and only then they can really get involved.
Thank you for emphasizing on the need for training, and there are volunteer training programs that are available. Before I open up to the audience, one last question from me, sir. So you have been changed gears from anesthesia to palliative care and have spent many decades not just caring but also making a difference. So what has made you continue with this unwavering compassion, resilience, and passion even after several decades? Because one of the things is, if we get too close to a patient or too involved, I can't take it, or there is a risk for compassion fatigue or burnout. So that's one of the reasons people think I will just look at the diagnosis, I will treat the disease and carry on. I can't go any further. So any advice for people sitting here with that kind of a thought, or how do we continue with that compassion and passion?
Not advice, Jennifer, but sharing the experience. And maybe when I have done, Jennifer, you yourself could answer your own question about your own shift and Reena's shift from radiation oncology to palliative care. But friends, I think it's an amazing privilege to be a healthcare provider. We have an opportunity. Hey, think of all the human beings wandering around there. What percentage of them would be having a job that they enjoy doing? 95% of them would be doing something because they earn a living, they need a living. And we have the special privilege to do something and still maybe get a salary and make a lot of meaning to our own lives. So I don't think I shifted away from anesthesia. I just started doing some usually ignored aspect of anesthesia. Our textbooks, even in those days, had those two chapters, acute pain, chronic pain, etc. Nobody just did it. So we started doing that, and I think it's an extension. Patients taught me that they are only made of nerves. I gave a successful nerve block to a patient. I was very happy and I was busy patting myself on my back. And we went home and killed himself that night. Because when I asked him, okay, this pain relief will last for 6 to 9 months. If you have pain, come back. Otherwise, you need not come back. He got the message, but his disease was incurable. He killed himself. My guru. He gave up his life to teach me a lesson. So I do this work of relieving suffering because it gives me a lot of meaning to my life.
Thank you, sir. We have some any questions from the audience here before we go to some questions that have come on chat? Anything you would like to ask, sir? You all can think. So there is a comment from Vidya. Thank you, sir, for your thought-provoking, inspiring talk. There is indeed a need for greater awareness among doctors. Would it help to have a session on basic palliative care for postgraduates combined with mandatory university research workshops? This is Dr. Vidya from Head and Neck Surgery.
Dr. Vidya, that would be so absolutely important. I don't know about here, but I know that in some oncology centers, all the residents, the senior residents have a rotation in palliative care. That would be very, very valuable. But even current, the inclusion of palliative care is only officially in the undergraduate curriculum. How about postgraduate courses? That has not happened. That will be, Dr. Vidya, I totally agree that that will be very, very valuable and essential.
Thank you from Hassan. How can we integrate artificial intelligence into palliative care?
This inevitable question that takes me out of my depth always comes in. Doctor, the answer is very simple. I don't know. But one thing that I expect, that even if all the other specialties are become unnecessary and robots take over everything, including radiation oncology and even surgery, with only a few people sitting and guiding it, palliative care will be still there. Because it's very difficult to get robots to be compassionate, to hold a hand, to wipe a tear. And I don't know, but one of the positive things that I hope to see is now there is this frustration of not getting enough support for patients when we need an ultrasound, when a CT scan cannot be afforded. So we don't know what's happening. All that will become much easier is what I expect. But a long time ago, I learned this lesson from one of my teachers, that when you don't know the answer to the question, deflect the question to the audience or to the moderator.
We'll go to the next question, sir. For want of time. So Dr. Jojin is asking about the community-based palliative care model at Pallium.
Doctor, I don't know if there is any public health people, community medicine people there, they would know the Astana Declaration of 2018, 7 years back. That's a global declaration. A renovation of the old Alma Ata Declaration, which everybody may have heard about. Astana Declaration said it is a global policy that healthcare should adopt, that healthcare should reach people where they are when they need it, where they are. If you don't know, I can assure you that it is true that the most needy patients never reach you. They have been abandoned, they are suffering like tortured animals in some village. Healthcare has to reach them where they are. The second thing is, part of the important message in Astana Declaration is, healthcare cannot be complete unless it incorporates education, agriculture, food, transport, and several other things. Only if all these come together, healthcare become healthcare, because health is physical, social, and mental well-being. The only way of providing true healthcare is by allowing the community to come in. So Trivandrum is not too far away. Very easy to get over there. Take the train from Katpadi. When you wake up, you will be with us. Come and visit us. I'll take you out on home visits, or our team will. You will see where in rural areas some palliative care OP set up in one place on every Tuesday in a hall that belongs to a mosque. In another place, it was in a Saturday, every Saturday in the afternoon, on Saturday in the morning, on a lower primary school, Saturday holiday. So there the local volunteers, willing people are trained. We provide training to them, and they start palliative. They take the initiative. When we go on home visits to those areas, they join us. They will know a lot more about the patients than us. Even if we try hard, they will know that this child's father is an alcoholic and beats up even the child with cancer. These things we need to know, and those we will know only if the community is also involved. So this is what we do. We try to reach people where they are, meaning that we have only in our center only 14 inpatient beds. We have 7 teams going out on home visits every day. We are not doing anywhere nearly enough. Some of the patients are seen only once in a month, or the more sick patients may be seen once in a week, that's all. But because the community volunteers are involved, not everywhere, some beginning, then we are able to give true health care for people who need us most.
Thank you. Are there online courses for post MBBS in palliative medicine?
Very many, including for people, for interns. That is during house residency, you can do those courses. There are online courses. I think I'll like to type out the website address. It's palliumindia.org, not com. PALLIUM, Pallium India, one word, .org. And then look for training, the link to training, and all the courses are listed there. There are self-directed courses also. You can enroll, do it at your own time as a virtual thing. And of course, in-person courses are there. But there are some things that are difficult to learn online. You don't get to experience how a nurse or a doctor interacts with the patient. It's not easy to teach the theory of it. Say, if somebody is suffering, we never stand and look down upon them and see them. We sit down beside them, not too close to, for it needs to be touching, but close enough to lay a hand on a hand if somebody cries. That kind of thing, the expression that you will have, the empathy, some of the things can be learned only in person. I was telling Reena that our whole work at the national level is called DEF, Demonstrate, Educate, Facilitate. So online you can do a lot of learning. I would still encourage anybody who has done only an online course to have an attachment to a palliative care center and see how exactly some things are done.
Thank you, sir. Any questions from Reverend?
Thank you, sir, so much for the meaningful interaction we have. So I'm from chaplains department. I'm Chaplain Raja. So as the palliative care, this is evolving, coming up. So as a chaplaincy department, as a role of chaplain, also evolved to how we can, as a chaplain, that we can meet the challenges as is in this field.
Thank you. I did not go into some areas at all. Our role is to relieve suffering. And generally, as Cecily Saunders said, the suffering can be in the physical domain, the pain or breathlessness, the social domain, including the financial destruction that we talked about, and the abandonment and all those issues, emotional issues, depression, anxiety, guilt, and some of them going into depressive illness itself or anxiety disorder, which needs to be treated. And the spiritual domain. Now, generally in the Christian world, which forms 31% of the global population, chaplains are integral part of palliative care delivery. Every palliative care program would have at least one chaplain. So that their training generally is to give total care, and they are the ones who find the social problems also very often, and they are trained to give it without a religious bias also. So whether it's a Christian or Muslim or a Jew, the chaplains will generally deal with that. There are some where the challenges of religion come in and some people believe differently. Yes, that is true. But what will happen to the rest of the 69% of the global population? So who gives spiritual care? You and I have to give it. What we mean by spiritual care cannot be equated to the religious support. My spiritual domain of my life, I would say, mainly rests on two aspects. One, the meaning and purpose of life. If I have nothing to look forward to, I keep saying, oh, what's the point? I wish I were dead. It would be easier for everybody if I could go today. The loss of purpose, the loss of meaning, that's one aspect. The other aspect is about connectedness. What connects you to this world? Take a moment to think. For some of you, it would be religion and faith. God is your connection, not for everybody. For many, it's the family. And what else? Do you think some people are connected only to profession? I've seen that. A friend of mine, a pediatric surgeon, spent his last 9 months in absolute misery after the diagnosis of cancer. And he went on saying, if I cannot operate, I do not want to be alive. No, not common, but even that happens. Your environment, patients who are admitted, sister, you say we'll discharge him tomorrow. 4 o'clock she gets up, packs everything, and is waiting to be discharged. And when does all the billing and formalities get completed? I am yet to see the hospital where it's completed before 4 o'clock. So from 4 o'clock in the morning till 4 o'clock in the afternoon, they are waiting to go home. Why? Because they feel an outsider here. They have lost their world. They want to go back to their humble home, the little mat on which they lie, That's home. So it's also about that connectedness, and achieving that is also our role. So even if the environment, which is in the majority of the world where there's no chaplain, all of us, nurse, doctor, volunteer, social worker, pharmacist, whoever it is, we all have to play the role of that friend who will make life meaningful for them and who will make them feel connected. Like I earlier mentioned the article by Christopher Booth, who said, first of all, I feel loved. There he was talking about a home visit that he made with our team. He went to the village and asked the person, one person was living alone. What does these visits mean to you? He was expecting the answer without the I'll have been in pain or something like that. And he, of course, translated, he said, first of all, I feel loved. Can you make that part of your practice? To give the love that every human being should have for your neighbors, love thy neighbor principle. And that's also part of spiritual care. So, Mr. Raja, the chaplain is trained officially to give it. But I strongly believe you should train every one of us to be able to do basic spiritual support, looking after the meaning and purpose of life and helping people to feel connected. If by nothing else, by giving love.
Thank you. Any, Praveen?
Thank you for your insight, sir. I am Praveen. I'm a medical oncologist. It's not uncommon for us to run into a situation in which there is discordance in the patient's family as to their goals of care and treatment preferences and escalation versus non-escalation. So it's not uncommon for us when the patient says that I do not want escalation of care in case I land up in the emergency with what you feel like an irreversible scenario. I don't want to escalate my care into ICU. Whereas the patient relatives are obliged to take a call in which they want escalation of care, even though they understand possible irreversible scenario. So I just wanted to understand your perspective on this, sir.
Dr. Praveen, thank you for asking that very, very common issue. If you ask the question to a Westerner, mostly a doctor in a Western country, they will say it's the person's right. Here also, in theory, if I am ill, this is my life. Primarily, this is my life. Chandriya would have only a second authority over my life. So my decision should count. But Dr. Praveen, if you go against the family's wishes, you know it is not possible. You also know that dead people do not go to court. Living family members will go to court. The basic thing is the Western world or global North go by, mainly by the principle of individual autonomy. This is my life. Whereas in our culture, or in almost all of global South, it is collective autonomy that counts. Yes, this is my life, but it's also Chandriya's life and my children's life and my friend's life. So that opinion is very important, and you will be obliged to go by the family's wishes. It's not easy, and we cannot always win. We cannot cure every disease, so we cannot solve every problem. But most of the time, we are able to get over it. Sorry, Jennifer, I'm going to take at least 2 minutes over this. Very often, the problem is we explain the problem to the family. See, even if we put him on a ventilator, it will be a limited time. And his dying process may be longer, but it's unlikely to come back to reasonable quality of life. No, doctor. I am sure we have We are praying. We are praying. I know that prayer can solve everything. I am sure God will be on our side. Doctor, you please try. But we have the data. Dr. Praveen now says we have the data. We know that at this point of time, a return to normal life is not possible. We will only be, but doctor, I am sure that is not true. I am sure he is going to recover. You are giving up on him. Don't give up on him, Dr. Praveen. But you see, and this is like a game of tennis. Dr. Praveen bats from there, and there would be a great person empowered by love batting from the other side. Never play that game of tennis. Start by jumping over the net and going to his side or her side. Suppose we are sitting in two chairs. I will not be on the opposite side of the table. I'll have him on the side of the table, close enough. And the first thing that I'll do for jumping over the net is to acknowledge his side. I see that you love your mom very much. I respect your love. With all her suffering, she is lucky to have somebody like you with all the love. I'm already on his side of the court. You want to do the best thing for her. I also want to do the best thing for her. Let us talk about it together. Now, I think this conversation of validating that person's genuine interest, and I am going to help you. I'm going to help her. I'm going to help you. And that will be a great beginning for a more meaningful interaction. And then gradually, I'll try to ask him, hey, has your mom been asking questions? Yes, initially she used to, but now she doesn't. Do you think it could be because she doesn't expect that you will give an answer? If your face changes, wouldn't your mother know? Wouldn't your mother be able to distinguish between when you are telling a truth and when you are saying a lie? And if after all my arguments he doesn't give permission to do what we recommend, I would say, okay, I'm not going to do anything against your wishes. Let us wait. Now, just let me find out what all questions she has. Because I know from experience that people have great anxiety in them. They have many questions that they haven't answered. They don't get answered. They may have things to do. Has your mother ever expressed any wish to do something that is yet unfulfilled? We'll find out those things. Let me explore. So I may get a conditional permission only to ask her questions. I may not have the permission to answer the question. And then Dr. Praveen, 2/3 of the time or more, they would already know. Oh, they think I don't know, doctor, but I know I have cancer, don't I? I'm dying, right? This is the question that comes back at me. So with these conversations, very often one conversation is not enough. And sometimes we may have to say, look, I see that you still have a lot to think about. I've told you of very difficult things. Shall we have a conversation day after tomorrow? But the problem is Dr. Praveen wouldn't have this much of time. And certainly he can't do it day after tomorrow. Which is why no Dr. Praveen can work alone with this kind of thing. They need you also. In our unit, we have more medical social workers than doctors. We have 10 doctors, we have 12 medical social workers. We have 2 psychologists working with us. And we find that that's very, 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 very valuable. They cannot give all the information that I can, but they can certainly get the questions. They can build the relationship, make them feel cared. And then Dr. Praveen needs to go in only to put in the medical facts. And still you may fail. Or you will succeed, you think everything is okay, and then will come the son from New York. The cost doesn't matter, doctor, save my life. Do everything. All the weary work to start all over again.
Thank you, sir. Any other questions, maybe?
Good afternoon, sir. I'm Dr. Ashwin, working in medical. Ashwin, sir, assistant professor, medical oncology. This question has been puzzling me around so many times. There are some subsets of malignancy, like for example, gastric cancer or like triple negative breast cancer or ovary. We know based on the data that if they have a node positive or especially the chance of it coming back is very high. But for a point of time, maybe the chemotherapy or the surgery or radiation, they'll be cured for some period, but the disease comes back at some later point. So many times patients have that fear of recurrence. So my question is like, how do we is palliative integration of palliative care at that point going to be beneficial for the fear of recurrence and also for those malignancies where we know that the chance of recurrence is going to be very high? Does it make any benefit, especially in these? Thank you.
Dr. Ashwin, right? Is that the name? Dr. Ashwin, thank you. I don't know about you, Jennifer. I know with guilt that the problems of cancer survivors are something that we do not effectively address. They're a much neglected population where they live all the time fearing the recurrence most of the time. And Dr. Ashwin, it's mainly about being available to answer their questions. And so kind of you, thank you. And also, it's about helping them to live with some uncertainty. If we just say meaning like something like just pray, nothing will happen. People are not fools. They know that other people have told them that there is dash percentage of recurrence. So the first point is they should have their anxieties addressed. We find that at least 75% of the time the fears are needless fears. And then the real fears, true answer is given and they have a chance to come back and answer the question. And somehow during our conversation over 2 days or whatever, the main message that we convey is not a lie. No sense lying. So that there is an excellent chance of no recurrence. But if at all it happens, we will be there for you. If it happens, you know that you had this treatment and that has helped you so much. And we will help you to live as well as possible. I don't have all the answers. The problem is they have also gone through the suffering of the treatment. You would think that they've gone through once and now the recurrence they'll easily deal with. But they almost invariably say, I don't want to go through that again. And there, we are there for you at that time. We will do the best. We'll work with Dr. Ashwin and others. We'll do our best not to cause that, not to give you any treatment that causes that suffering. And also, Mr. So-and-so, medical science has also evolved so much in those days. At that time, the chemotherapy caused so much of suffering. But now we know better. We can do this, this, and this, and the treatment will be much easier. Thank you.
We can take one last question. Dr. Vidya has put about something about AI, a few ways in which AI can be of use. It can help identify unmet needs in vulnerable people by data analysis, can be integrated into mobile apps for patient or the caregiver. Patient status can be tracked, advice offered when necessary, and some scoring can be devised for this. These are all AI-based therapies, much used in oncology to address also mental health needs. So for needs identification and assessment and integration, she's saying AI can be. Sharon?
Can this be saved?
Sir, thank you for your talk. I'm Sharon. I come from a hematology background. There are some diseases where we know very early will do badly.
Very early?
Very early at the point of diagnosis itself, we know will do badly, despite the treatment that we give. Very simple is even multiple myeloma. We start by saying this disease is incurable at this point in time, world over. But do you feel that, like you said, the global north and the global south, do you feel that socio-culturally it's very difficult to talk about death and dying and high risks of dying early in treatment in our part? And very often, if your center or you're the doctors who do that, do you feel that patients go away just because they don't want to hear that truth? So do you approach it a little later on, or but sometimes very often, very early, as a referral center especially, we get people who are fully evaluated outside, and you have to tell them that whatever we do, there's going to only be a 30% chance of survival. And that people are not able to accept that. Maybe a little later in the disease, you tell them, okay, this has come back and like that. But early on, do you feel that there's resistance to talk about death and dying?
Dr. Sharon, did you say? Dr. Sharon, thank you for the question. Very important, of course. Sorry, Jennifer, that will be another long answer, but I'll try to make it as short as possible. When we communicate bad news, we must emphasize on the most positive points in the situation first. Just saying, okay, this cannot be cured, leaves them with no hope. There's no life without hope. And generally in 20, thank you. Generally in about 48 hours, they come to terms with some of them, some other things. Then they have many questions inside them. Will this happen to me? Will that happen to me? And they also need to be answered. So it cannot be completed in one sentence, one day. And secondly, on that day, we cannot expect decisions. You are saying that we will follow this regime. It's a rare person who immediately thinks logically and says, yes, Dr. Sharon, do that. Generally, they need time. Dr. Sharon, even when you go to a restaurant and the waiter gives you a menu, you generally ask him 5 minutes, because the serious discussion about to choose choice between mutton kurma and something else takes 5 minutes. There also people need time. And usually it's a couple of days at least. Sorry, I was trying to compress a large answer into a small bit, but I would encourage everybody to seek some training in communicating bad news. There were several potential challenges that will come up, but learning that will be very, very valuable for the patient and for you, because thereafter life will be so much easier for you.
Thank you, sir. Thank you so much. It is not too easy to give answers for such complex questions and real life scenarios. You have really helped us. We want to take this opportunity, sir, to thank you and ma'am for coming over. And it's really a privilege to actually listen and hear from you. I think every time we hear from sir, it's a reigniting of some old learnings, and always there are many new things to take away. So I'm sure that is the experience of all who are here and those who have joined us online. So on behalf of CMC and the department, we want to thank you and give you a small token of appreciation. So thank you.
Thank you, everybody. I know I took a long time. Thank you for your patience. Thank you.
Thank you for joining online, your active participation, comments, questions. Thank you very much. You want to say something more, sir? You're at. We already have. Yes, thank you.